And thank you very much for joining us for this instruction course on deep anterior lamellar keratoplasty. I know it's a really early session, so I thank everyone who has made it here. We have quite an interesting set of talks regarding DALK, and I think it's a great surgery. It gives me great joy every time I'm able to save that endothelium, DM endothelium complex. So we have an excellent set of instructors here, great experience across the board of different techniques of doing DALK. So without further ado, we'll start the talk. So I'm going to run through a little bit of basic DALK and DALK steps, especially the big bubble DALK, and then we'll hand it over to our next masters who will take other steps. Move nahi ho raha. Move nahi ho raha bhaiya. So of course, we don't really need to get into why DALK. We all know it's because there's so much advantages we're leaving behind the endothelium there. There's a lot of wound strength that we have, less intraoperative complications, patient's healing time, and of course, we can taper the steroids faster. And there are a wide variety of indications that we could use this surgery for. Ectasias are one of the most common that we rely on this surgery for, of course, but they can also be for various types of dystrophies, corneal opacities, and certain infections, as we'll be seeing later through our talk. Bhaiya, move nahi ho raha hai. So the points to keep in mind when we are planning our DALK is what is the underlying pathology that we are trying to treat there, what is the depth of the scarring, what is the pathology depth, because that's very important to know whether there's already involvement of the anterior, mid, or posterior stroma, whether the DM endothelium is scarred, and of course where is the involvement, whether it's a centered, decentered, apical scarring, and as we can see, whether there's scarring of the endothelium. So here I find the anterior segmentosity, in addition to, of course, our clinical examination, quite useful, especially to try and measure the depth. In a lot of advanced ectasias, keratoconus, you can still have a lot of scarring. That does not mean that we can't do a DALK. So we have done DALK even for a post-hydrops case once it's scarred, but you really need to measure it and look at how that opacity is and plan your surgery and your technique for surgery. So there are various techniques, and the most common and popular being the big bubble, but over time we've realized that a lot of manual dissection is our fallback method or the first method of choice for this surgery, and we'll be going over a few. The beauty, I think, of DALK is that very often we need not have any high-end diagnostics or instrumentation. We don't need very costly instruments. We can manage the surgery with a lot of instruments that are available to us in our OT already. And I think if we are starting out DALK, one of the most useful instrument or must have in my book is a blunt tip scissors, because it really helps with your dissection, be it your big bubble or your manual surgery. So when we are planning the big bubble, very important to remember if you're using a needle or a cannula. So it's important to remember, especially when you're using the needle, what is the location of your needle, what is the direction of your needle, and the depth. So when we mean location, you try not to be too peripheral. You need to be directed towards the center, and of course the depth, because if you're too superficial, you're going to get a lot of emphysema and not the big bubble, which is usually formed between the stroma and DM endocomplex or the predesematic layer, depending on the type of bubble. So the next step is releasing the bubble. So once we form that big bubble, we need to release it, and here one very useful tip is to put just a dot of viscoelastic on your bubble there to slow down the egress of air. Otherwise, it will come out in a big gush, and when you're releasing your bubble with a sharp instrument, be it your side port knife or any other instrument, you might actually nick the DM. Also, another useful thing is to do a very shallow paracentesis to reduce the pressure in the eye, so that the bubble does not egress with a sudden gush of air out. So I'll just show you as we're doing. This is the shallow paracentesis. I put in a small bubble into the AC, and this double bubble really helps us, because when the big bubble is in the AC, that other bubble would be peripheral, and once you have released the big bubble, it moves centrally. And this really helps if you've taken a few attempts to make your big bubble and there's a lot of emphysema there, not very visible, not very clear if you release the bubble, then that movement of the bubble in the AC really helps. Followed by the quadrant dissection of the stroma, which is quite straightforward. You need your blunt tip scissors here, absolutely essential, and then a careful quadrant dissection would help you to unmask that mirror-like glaze of the DM endocomplex. Now, what are our alternatives? And this will be taken in detail by our next speakers, but just because we have a deep scar does not mean that you can't go ahead with the DALK. This is still possible even in a post-hydrops scar. So a lot of people are very worried about the bubble and challenges with the bubble. So just a few things that you need to keep in mind. Of course, the instruments, as I said, you don't need too many major instruments, but a few important ones like the blunt tip scissors. And of course, how much pressure is required. So a lot of people use either the 5cc or 2cc syringe. It would depend on what your hand is good with. The idea is that you should have a controlled ingress of the air and not a sudden burst of air there, because if in case you're in the wrong plane and you suddenly push in air, there'll be a lot of emphysema and that will blur your next step. So I personally use a 2cc. The only downside to that is in case you've not filled it fully, then halfway through you may run out of air and your bubble will not be complete. But as long as you have the full syringe, it's going to be a very controlled ingress of the air. So how do I know that the bubble will form? And this is quite an easy thing that you look. If you look at this video, first the air comes out, but once it starts forming in the center, you see these little spoke kind of structures that are there. Look very closely where the needle is, and you see these slight spokes coming out, and that usually denotes that you will get the bubble even though there was a slight emphysema. To show the contrast, I'll play the other video where you can see that when the needle is inserted, the bubbles form almost like a small, just like a blob, and they don't really spread out. So if that is there, please stop. You're not going to get the bubble from there, and you're going to make the entire cornea emphysematous and not be able to take the, go to the next step. So this is what I was saying. Understand the air dynamics. If your bubble or air is coming backwards, you need to stop. Don't keep injecting, because then it's not going to help. And in this case, you'll see how it suddenly goes into a full, it spreads, and that's much more difficult to get the bubble after that. Next question is, how many times can you try the bubble? So there's really no rule to that. So you can try as many times as long as you have a good visibility of it. And it becomes more difficult once you've tried a few times, because the air tries to pass into the point of least resistance or path of least resistance. So you can see there's a lot of emphysema here, but in the next step, you can still achieve that bubble. And all of this is being done with just a 30 gauge needle. Of course, a cannula makes it much more easy, less chance of perforation and complications. When the air enters the anterior chamber, okay, you have to make sure that it's not a perforation. So if the air comes in from the periphery, you know that it's just passed through all around and come through the trap. But if it's come directly into the center, you would suspect that you've had a microperforation and should probably take it a little more conservatively. The last thing I'd like to show is, suppose you made the nick, but your nick was not deep enough. It was very superficial and you can't really find the plane. Then there are ways to try and find that dissection. But if not, then you would have to resort maybe to a manual way. So the idea is to get that instrument into a smaller, that space, because otherwise your, that entire creation of the bubble that you've done would be to naught. Here finally we found the plane, and then we'd be able to uncover the DM. So just in case we've done a manual DALK, it does not really mean anything. Very good results even with manual DALK over time. It's just that the big bubble DALK has extremely good early results, and I'm sure Dr. Rishi would be covering that. It's not that DALK does not have complications. There are certain complications that we have to keep in mind to try and prevent, and especially many of them have a lot of allergy, especially the ectasias, so you can have surface issues which you need to deal with. So I'll hand over the mic to our next speaker, Dr. Rishi, who will be telling us his excellent technique of the groove and peel and how to go ahead with manual dissection. Thank you very much.
Thank you, Dr. Sharon. Am I audible? Yeah. So after that excellent talk on big bubble DALK, I'll go to the other technique of deep lamellar keratoplasty, which is the big bubble screen. स्क्रीन नहीं आ रहा है अच्छा आ गया Thank you, Dr. Sharon, for making me part of this interesting course. I wish we had more audience at 8 a.m. in the morning. So, as we all know, deep lamellar keratoplasty is one of the difficult techniques in cornea, and that's probably because it is a lot of the surgery is actually technique dependent rather than machine dependent. There's so many techniques of deep lamellar keratoplasty. The big bubble was covered very nicely in the previous talk, but there are various other techniques that have been described in the past. And the reason there are so many other techniques is because all techniques have some flaws or the other, and no technique is perfect. So this was already shown. So ideally we would like a big bubble in every case, and it's a very nice technique. But there are problems with big bubble. You don't get it all the time. Sometimes you can end up with perforations and other complications. You may end up with a type 2 bubble, which can sometimes be disastrous. So in addition to that, there are some cases where a big bubble may be precluded. Suppose you've had a previous eye drops, a deep scar which is involving the desmoid membrane, a very peripheral ectasia, because the big bubble will not reach in the peripheral cornea. And of course, any other contraindication for a big bubble would probably be an indication to do a manual DALK. I of course use it as my first choice technique in most of my cases, because in my hands that works very well. So earlier when people used to do manual DALK, this is what they used to do. They used to use a sharp instrument to peel layer after layer, and that does work, but problem with that is you're using a sharp instrument to dissect, so you may end up with a perforation, and that could happen centrally. Second thing is you can end up with an uneven bed if you don't do a desmetic DALK. There are ways of managing it, but it does preclude the outcome. So if you're trying to use air, you can also use air to kind of opacify the stroma and thicken it, so that you can, when you're peeling layer after layer, you can find out how deep you're going by looking at the removal of that opacified stroma. So that's called the air insufflation technique, and that also works well. So that's kind of a modified air insufflation technique that I am doing here. It was of course unintentional. I was trying to get a bubble and we got this. So we use that opacified stroma to make your dissection safer. Dr. Sugita from Japan had described this technique of hydrodelamination, in which he was essentially doing the same thing, except instead of air he was thickening and opacifying the stroma with fluid. This also works, and it's important to know all these techniques, because you can use these actually as your recovery methods when you have a problem in DALK. So what I do is I use this when I'm doing a manual DALK. If I need to take out one more layer for some reason, I will thicken one area, and then that becomes a safe area to make another incision and continue the dissection. So you use the principles of the technique to do something else. That's essentially what I wanted to mention. Melly's technique was described earlier, in which he used to use a dissector, just like we use in DSEC, at about 350 or 400 micron depth, and dissect the whole cornea, and then you refine it. The problem with this is if your cornea is of an irregular thickness, like if it's a scarred cornea or an ectasia, which are usually the indications of DALK, your bed may also be irregular. Also, you'll be ending up leaving some stroma behind, so you'll have interface related problems. So the challenges of the usual techniques are that you can have sharp instrumentation, which can cause perforations, too much or irregular stromal bed being left behind, which can cause scarring in the interface, and repeatability is low because the techniques are highly dependent on surgeon skill. So what we started doing was this technique, which I call the groove and peel, in which basically we make a partial thickness trephination in the cornea. So I use a freehand trefine. You can use a kind of a guarded trefine of a fixed depth, and then in this case we had tried a visco bubble but didn't work. So we use a scissor like this. Here I am using a universal corneal scissor, which we use for ECC, but now I use a separate scissor. So basically you create a little groove underneath your partial thickness trephination with the scissor. So you're doing like a scissor dissection all around, and you kind of, after you've completed a 360-degree round, you go at a deeper plane. Basically you keep spiraling deeper with each dissection. You go in closed and open the scissor under, and then you cut the tissue that has been dissected. So you keep doing this till you start seeing that glassy DSOUZA layer, which is the predesmatic layer. And once you've seen that, expose about 2-3 clock hours. At this stage, one could do a paracentesis to make the anterior chamber a little softer and reduce the chances of a perforation. So you can see about 2-3 clock hours has been exposed, and once that is done, you can use another forceps to kind of give counter traction, and with this tooth forceps you can basically grasp that central island of stroma and peel that entire stroma off the DSOUZA layer using stretch forces that is distributed over a large surface area. So because the stretch forces are distributed over a large area, the chance of perforation becomes a lot lesser, and you can see we got a nice clean dissection with a smooth bed, as good as you would get in a DALK. And you can do this again and again. Sometimes you don't get a pre-DSOUZA layer if you start stripping it very early, and that will have a very telltale kind of an appearance, and you'll have a lot of resistance. So as you keep doing, you'll realize when you are at the right plane. So I'll just made a little video. I'll just show that to you as well. Do you have sound? It's okay, doesn't matter. So again, we're, as you can see here, we are doing that peripheral groove. And here I'm using a special scissor. You can see the scissor has a narrow tip and a blunt, a narrow anterior part, and the tip is blunt. So that makes it safer to introduce into the stromal lamellae. And because it's narrow and flat, the profile is very flat and thin. So it's easy to introduce between corneal layers, and it doesn't pinch the deeper layers, so it becomes safer to cut. So this is one thing I do. When I've done this groove all around, sometimes you have this huge bunch of tissue in the middle. So I trim the edges of it so that it doesn't come into my way, and it doesn't preclude my visibility. So now I've exposed about 2-3 clock hours of the DSOUZA layer, and you can see once you've got a good amount of exposure, that potential space is opened up, and just using stretch forces without any instruments in the central cornea, you can peel quite nicely. That last part you can just use some sort of a blunt instrument and just kind of peel it off, and you can see that it's quite bad. There will be small fibrils, but you know, once you put fluid, you'll realize that they don't really optically matter much. You can see the very first day, this is, you can see the air bubble there. You can see the interface is very clear and cornea is compact, just like it would look in a big bubble DALK or even a penetrating keratoplasty. Okay, and similar principle you can apply for even large advanced ectasias and a very large diameter graft. So this is a case of a keratoglobus. So doing a very careful dissection, and then you can just peel this off. In fact, there's no fibers which are attached. It's like a LASIK flap. It just comes off very easily in a keratoglobus for some reason. Even therapeutic DALKs, because of the edema, the stroma peels off quite nicely. You will see that here. So this was, of course, this was not a groove and peel technique. This was a case that I had done at LV Prasad when I was there. So this was a patient with a total limbal stem cell deficiency unilateral, with a thinned out cornea and scar cornea. So because there was a risk of amblyopia, we decided to do a DALK primarily, and you can see I've done actually used this iris repositor to do layer by layer dissection, and then put a large diameter graft, which is I think about 11 mm. So after removing the entire panels, basically you're doing a DALK, and after that you put we put a cultivated limbal epithelial transplant on top. So you can see we managed to save this child's eye and prevent him from going into amblyopia. So it's not like this technique, you can't have a perforation. If you've had an old hydrops or some scar, you can end up with a perforation like this. But in most cases, it can be managed very well. As you can see here, you can see the triangular, you can't see it so well, but there's a small triangular perforation in the center. But this patient did really well and got 6/6 vision eventually. So one of these, this patient had both eyes done. One was done with a big bubble DALK and one was done with a groove and peel technique. And you can see both look equally clear. You can't really make out which one is done by which technique. So manual techniques are a good alternative to big bubble, especially in difficult scenarios, and I in fact use it as my primary technique of choice. It makes DALK safer and more predictable if you use the right instruments, of course. My small tip would be use principles of various techniques to arrive at your own technique, and even when you're doing one technique, if you have a problem, you can use principles of the other. Don't stick to just one technique, and that will make your DALK a lot more fruitful. Thank you.
Okay, good morning all, and thanks, Dr. Sharon is not there, Dr. Sharon, and for giving this opportunity. So I'm going to discuss role of DALK or deep anterior lamellar keratoplasty for infectious keratitis. And to begin with, basically what are the indications or contraindications of doing therapeutic DALK. So indications like worsening infections, as in any other surgical management of infection on medications, or poor compliance of medications in a patient of worsening infection, or in undiagnosed cases of infections. Extreme thinned out or ectatic cornea, corneal perforations, lens involvement, retrovirus exudates, limber involvement are usually a contraindication for performing DALK for obvious reasons. Infections where a known potential for doing DALK is most commonly is acanthamoeba keratitis, with fewer indications like fungal keratitis, with controversial indication is like microsporidial keratitis and bacterial keratitis. Advantage over doing PK or medical interventions in acanthamoeba keratitis is lesser chances of recurrences, lesser chances of development of cataract and glaucoma, minimal chances of endophthalmitis, faster visual rehabilitation, and better ocular surface management. So with this I will show some videos or some cases. So this is a case of a 45-year-old man who came to us with a corneal infiltrate, with a basically history of foreign body fall of almost 1.5 months. We started based on corneal scraping. We got acanthamoeba cyst, and then started treatment with the PHMB 0.02% and chlorhexidine 0.02% with intensive anti-parasitic agent, but still we could not get the resolution, and the patient was having severe pain. As you can see the intraoperative picture, that patient was having severe limbitis as well as uncontrolled infection, and there is central thinning around 45%. So we decided to go for surgical intervention, and preferably for deep anterior lamellar keratoplasty. So as in all surgical procedure for infection, we need to find out the exact margin of infiltrate. That should be done by removal of epithelium, and if at all anterior chamber infiltrate exudates are there, we have to take it out by washing that. So first of all, location, and then marking of the infiltrate, and then center of the cornea, and basically to locate and complete more than 0.5 to 1 millimeter, depends upon the type of infection, safer margin to avoid recurrence of infection. I take a lamellar, basically very sharp, you can say that definition is very shallow, and then with the help of crescent, you can see the thinning is there. Removal the anterior lamellar. This is a very important step in management of infectious keratitis when you're performing DALK, because in normal, like we can do without removal of anterior stroma as well, but in these cases we need to perform after removal of anterior stroma. And then as a routine procedure, as described before, we perform a big bubble technique in all cases, try to make it a big bubble if at all is forming. Then again removal of layer by layer to get rid of the infiltrate by manual, and then so have a better localization of the big bubble. As you can see, I'm using crescent. You can use any other little sharper instrument. I was trying to make big bubble because on table it was not very clear that I got it, but on the second attempt it was obvious. On a retrospective review of this video, I could see there is a bubble which is already formed. And then I injected. I will always use double bubble technique in this, where we put injection in air bubble inside the anterior chamber to locate my bubble because of poor visibility in these cases. And then gentle separation from the desmet. And then putting viscoelastic. This is my routine way of performing Lamellar keratoplasty, and then 4 parts of the posterior stroma, and then removal of that. After that, it's like a similar. Other thing which you can notice here is the endoexudates and hypopyon. Depends upon the organism. If you are dealing with fungus, it's a major no not to go ahead with the DALK in these conditions if you are seeing these endoexudates. But in Acanthamoeba, as we know that it rarely passes desmet membrane, so you can perform easily even in presence of endoexudates and hypopyon. There is no contraindication for performing DALK. So this is the case this is the post-op picture of the patient. Now patient has almost 6.5 year follow-up. I did cataract surgery later on. Similar case. This case was a little advanced case, followed up 3.5 months, presented with large infiltrate of around 7.8 into 6.2 millimeter with around 2.4 millimeter hypopyon, with guttering along with little bit of involvement of the scleral nodules. So we did the scleral deroofing. We could not get any organism. As usual, we see the scleral inflammation in the Acanthamoeba keratitis is inflammatory. We go ahead. We think about going for performing keratoplasty. And this is the basically largest Acanthamoeba therapeutic DALK which probably I performed of 11 millimeter. After initial trephination, got a decent big bubble in this, and the technique is little different as compared to the previous video where I use the sharp scissor and removal of the stroma. So this is the follow-up of that patient, and the very decent outcome. And this is the series which we have published in Indian Journal of Ophthalmology in 2020 of outcome of around 23 cases, and you can see the outcome of Okay. This is not free of complications, as we can see the recurrence. In this particular case, we got a recurrence, and then and the very interesting thing, the recurrence is presenting as a interface stromal cellularity with a lot of pigments on the endothelium. This should be suspected as recurrence, and but we continued steroids thinking of this is a stromal inflammation, but it presented like that, and then we land up into doing penetrating keratoplasty after that. So I think lack of time, I will just show this video from Dr. Paras Mehta. She performed for fungal keratitis. Usually this is not a very obvious indication for performing DALK, and literature only few cases are reported, particularly from Z et al. Group, and those are basically very, very early fungus infections, particularly in cases of fusarium keratitis where it doesn't go so deep. You can still get away with performing layer by layer and going ahead. But still, I suggest for beginners or patients, or basically for all the people who are managing infections, not to take it as a first way of modality for performing DALK in fungus. So this case was lucky, and this patient was lucky, and it could not get recurrence, but a very nice outcome and very diligently performed by Dr. Paras. So this is the obvious contraindication, looks like very obvious indication, but not to go ahead in this scenario. I said we have already burnt our fingers, and literature also supported only one anecdotal case report. So this case report was an anterior stromal cellularity, often misdiagnosed as viral keratitis, and this is came on to be microsporidial on biopsy as well as confocal. And we performed DALK, and it came out to be interface debris or sort of pigments, suspected initially inflammation, but came out to be a recurrence of microsporidia. Again, performed the PK, and but somehow could manage to save the eye. But this is not only one case, 2 cases, and literature also support not to perform DALK. So with that, I would suggest not to go for DALK in microsporidia. So there are few obvious differences in basically I can divide in 6 steps. Like in TDLK and DLK, the trephination need to be decided based upon the size of infiltrate. Anterior lamellar dissection is always mandatory in TDLK, anterior chamber wash to delineate the size of infiltrate. And double bubble technique always I found to be useful as compared to DLK. And big bubble formation and is almost same. But important thing is we should not leave any tit or bit of stroma because that can be the cause of residual infection. Thank you very much.
Can I have my slides, please? Thank you, Bhupesh. And I guess this should be the final talk because I would just like to convey to the next session in charges that we have got all half an hour delayed from the technical reason, not from the speakers, but we would try to see that we give you as early as possible. Thank you. So when we talk about DALK in complicated condition, we are talking about complication which can occur during the DALK or complication which have occurred before the DALK. The commonest complication we talk about is perforation, and perforation can occur at many steps in DALK. We'll just go few of them. Like one is perforation during trephination. If it's very thin cornea and we try to manually deepen the trephination mark, well, you can end up in perforation. Such kind of thing which you possibly can go for a manual dissection from opposite side and it can still work. Similarly, one case I'm showing where an uncalibrated trephine, I ended up having perforation which was pretty large enough for me to salvage and which was sort of almost 200-degree perforation. Classically, I would have said that we go ahead and do PKP. But then I thought that one area is attached, why not we try to salvage this by doing a manual dissection. So hence I took a few sutures on the area of perforation or opened area and I started dissection from the other side and I could finish the dissection. I kept one suture which was there on the opposite side till the end, and when I put the graft, and that's the time I replaced the suture. Post-operatively, well, everything was fine and patient did well. So even if the perforation is very large, you still can salvage. The another time which can be quite bad is perforation during big bubble. Suddenly you can hear the pop sound or burst bubble sound, and again technically we may be advised to convert, but again had unfortunate incidents in my hand. I missed out pre-operatively. There was a track which was going all the way down, and hence when I tried to make a bubble, there was a pop sound there, and well, that's the time where I lost my DM there. I went layer by layer dissection and left behind some amount of cornea on top of it, and finally when I reached there, I realized that it was not retracted and I could just put a small bubble inside and patient did well. Post-operatively, as you can see, this is the pre-op track which I missed out on OCT. Post-op patient is doing well and patient is fine. Another case of microbial keratitis which came and ended up with a perforation and posted for PKP bar DALK, and as you can see here, this was, mind you, this is not a descemetocele. This is now already perforated cornea, and I thought that if perforation is small, why can't we try to do DALK? Now the problem here could have been that you can have persistent edema in that region, which I did. You can have a sort of recurrent epithelial erosion or bullet there, well, which I did, but ultimately I could still save the eye, and ultimately I could still get to retain patient's own DM. Post-operatively, as you can see here, patient did well and finally is able to maintain a decent visual acuity. One more such case is the DALK in such kind of thin cornea, which keratoglobus cornea. Well, the interesting part there is you may have to do a very large dissection, and hence you might want to retain the peripheral limbal stem cells. So make sure you do not damage them. go for a deeper dissection, and as Rishi was showing, that you can go ahead and peel it off from the surface, or you can go layer by layer dissection and separate it out. The larger graph here, I'm doing a tuck-in DALK, so where I've taken a donor which is much larger than the recipient size, and after putting the sutures, you end up just tucking it inside. So as you can see here, I'm sort of tucking it inside. I do start with a spatula, but then I switch over to a forceps, a curved forceps, which works quite nice for the tucking in. And the rest of the suturing and the rest everything remains same. So as you can see from here, the huge amount of flattening which you can achieve and still retain the donor endothelium. Whatever we do, many times there are cases which may end up in a scar or something, which possibly is not something our aim in doing a DALK surgery. With the paucity of time, I really don't think I need to go into this case, which was quite elaborate, where I had to do quite a significant amount of ocular surface reconstruction, where we could ultimately save the eye and could do a DALK, though not big bubble, though not desmet exposing, but quite a posterior stromal, and ultimately did well. So to summarize, intraperforation in DALK is not uncommon. There are different steps of DALK where you can have perforation, you still can manage them. Sometimes even the complicated condition of the cornea can be managed with DALK, and rarely nowadays you need a keratoplasty. Thank you very much, and I guess we will conclude the session here.
Pleasure. Thank you.